Thank you very much. Ladies and gentlemen, let's remain seated for this next panel. It's 1 hour, and the Honorable Minister has obliged to remain in the room. And so let's just get right to it. Let's listen to a word from our partners who are active in improving health systems in Africa as we start the session. Media team, please. There's a video from one of our partners. Thank you, MSD, for everything you're doing for health in Africa. I would like to change the slides, if I may, because we're getting into a session on healthcare financing. Everything we're going to discuss in these 2 days needs money. So we would like to quickly get into financing. I don't want to give it a huge introduction because our first speaker for this session, Olumide Okunola from the World Bank, is going to tell us about building sustainable health financing models in Africa. Thereafter, we will have another, let's welcome on stage Dr. Olumide Okunola. Please go to his starting slide.
No, I just want to know if the slide in front there's going to be. Okay, so can we bring it on? Okay, thank you very much. I'm so glad that Honorable Minister of State, you have agreed to stay back. I'm happy that you are. So my presentation is to you. Oh my God, please can we go back to the start? I don't know. Okay. All right, so what do I press to take it forward? Okay, all right, yeah. So, ladies and gentlemen, we're going to be very quick, all right? 10, 15 minutes we should be done, even though I was given 20 minutes to make this presentation. But it's going to be a town hall kind of discussion, you know, the one where we're not going to leave this room happy with ourselves, but we need to tell ourselves the truth, all right? So, Honorable Minister, thank you for staying back. Sir, you will note that in the early 2000s, this is how Africa was being described. Africa rising because of what was in the soil. There was a lot of economic growth, right? Oil, mining. But now this is muted, right? Okay? There seem to be some challenges. Because we were focused on what was on the ground and not what was in our head. What's in our head is what would take us to that place where we need to be. That is the true Africa rising. And that is why, Honorable Minister, the true Africa rising is in this demographic structure. Africa has a youthful, productive future ahead of it. We have a favorable demographic structure ahead of us. In other words, Africa is ready to reap one of the greatest dividends ever. There's only one little challenge, Honorable Minister. Just one little challenge. This dividend is not automatic. Without you implementing some policies, deliberately, intentionally, you listed out those 5 things, we don't have a choice. In fact, if you look at journals, if you look at articles on demographic dividend, they ask, is Africa going to reap a demographic dividend or a disaster? But let's take stock. Let's take a step back. Where exactly are we? For a continent that wants to reap a dividend in its demographic structure. The simplest thing that you could give to human beings in the world is vaccination. All right? But this is a selection. You might not see it too well, but you can see the red line. That red line is saying these are African countries where childhood immunization coverage is below 80%. Even 70% is high, but when you have 30% of your kids not vaccinated, then it's a problem. My great country, Nigeria, Honorable Minister, we are 60%, meaning 40% of our kids don't have complete immunization. Africa rising, right? But look, there's a lot to be happy about. Infant mortality rate from the early 60s was north of 200. Now it's 45. But Asia is already at 25 per 1,000 live births. There's just one little problem. We will be where Asia is by 2050. That 25. That's too slow. That's the time we should be reaping that dividend, even though we are 45 now. Okay, look, we know the poor are not getting health care. This is under 5 mortality rates. The dark blue is the lowest income quintiles. The poor, the vulnerable, we know they're not getting health. Okay, let's look at how the rich on the continent are performing. That's like this. Okay. None of these countries on this slide, the richest income quintile is at the SDG level for under 5 mortality rate. Okay? All right, maternal mortality. From wherever you can see it, you can see high figures. All right? Nigeria is 1,000 out of 100,000 live births. But that's even not what I want to show, Honorable Minister. What WHO is saying is that, in fact, the blue line was the maternal mortality rate before and now. Guess what? It's worsening. Those are those red circles. Overall, health outcomes are poor. The lagging, when we compare to Asia, for instance, the worst part is there's even the potential of a reversal, especially because of the changing landscape in the financial architecture. All right? In summary, you can look at our health outcomes from how we're doing in terms of human capital index. A child born today, based on the amount of health and education available on the continent, how productive will that person be? West Central Africa, only 38%. Other parts of the continent, about 42%. Asia, 48% and rising. In fact, if you compare African countries in terms of the human capital index curve, that's where we sit. Ladies and gentlemen, if we're talking Africa rising, we got to be on top of this curve. You know the sad part of this? We don't even have a choice. And so, but why are things this way? Perhaps the biggest issue is this. And Minister, I'm glad that you've already started that conversation. And I'm just going to deepen on some of the examples that you've given in that very well-written speech that you read. We're not spending enough on health care. It is a necessary condition. It's not sufficient, but it's a necessary condition. And the best way to take the pulse of how much you're spending is what's the level of your public spending as a share of the national economy. In Nigeria, it's 0.5%, one of the lowest in the world. In fact, for the level of its size, it's perhaps the lowest. So it is for several other African countries. And you can see the African average, you can also see the global average. With this level of spend, in fact, if you look at the per capita, that is how much every African is getting in terms of healthcare, and you compare that to the basket of healthcare services that is required, significantly low. Don't let's even use things like the Lancet Commission of and all of those estimates. They are looking at $300, $270. Here, what we are talking about in Nigeria, for instance, is $13 per capita. And by the way, that's data that is still lagging. We could argue that this is probably because African nations were not making enough revenue. That's a fair and factual argument, and it should be part of the issues. And Minister, sir, in fact, that's the number one reason why I asked you to stay behind. One of the reasons when we go into the solutions. Because if you look at the tax to GDP ratios for several African countries, our average is 16. Nigeria is at 8%. You know, so how can you even spend what you don't have? Talk less of them say you want to give to health. But we'll come to the solutions. But clearly one of the problems. It then also means, however, that you are not also prioritizing healthcare within your own government budget. But let's hang on 1 second. How you prioritize for health within your budget is a policy choice. It is when FEC, for those who don't know, Federal Executive Council, that's where ministers like Minister Salako sits and big men. But if they make a decision and say, look, because our economic competitiveness is dependent on how much we prioritize within the budget we have, then the traditional 4% needs to go up. That's prioritization. And there's a reason why I'm coming here, as you see in the cases of China and India. Of course, in the absence of the money that government spends, it then means that citizens would have to pay out of their pockets. So it is no news that several countries in Africa, healthcare is funded out of pocket. And by the way, Nigeria has one of the highest out-of-pocket expenditures. You could also argue that the reason why we're not spending enough on health, we're not able to even mobilize as much public financing for health is because the debt overhang is large, and it is large. These are discussions and arguments that are, beyond me, but we need to recognize it. And I think some big men somewhere need to come together and say, you know what, for progress, let's have a discussion on this debt overhang. Because if you look at this slide, if you look at how much African nations were spending on debt compared to now, in fact, it's increasing. I don't know how much of the slides you can see. And this is money that could otherwise have gone into productive sectors like health and education. In fact, if you go back, but simply just to say, I wanted to show how some countries are spending almost 60% of their revenue on covering their debt expenses. But you see, beyond what countries are even budgeting for health, not everything is released at the end of the day. And this is just a sample of countries to say, okay, based on how much you have allocated to health, how much is even released at the end of the day. It's important to, again, look at the slide. Development assistance for health in the last 25 odd years or so. This is huge. A lot of people will think that what's happening is something we can probably wish away. This is our reality. So that we're clear, Nigeria, we're talking benefiting almost up to 20 billion in development assistance for health. If all of that is going to be reduced, is going to disappear, Minister Salako, the kind of discussion and approach that yourselves and Minister Pate is having is exactly the right thing to do. Africa CDC, we need to get our heads of state together. I don't need to go into the details of this slide. I think this even came from some of your studies, where you have some countries like Central African Republic, 90% is off development assistance for health. The effect might not be now. In the next 18 months, we won't be having this kind of conversations. This is important and needs to be prioritized. Okay, so what can we do about it? Let's take a breather now and go through. I'm just going to say some very simple things, but they're things, sadly, we need to take to heart. But before then, cheat sheet. Give me 30 seconds to just very quickly go through somewhat complicated slide, but it's okay. That's China. This is India. The red line is how much India or China prioritized for health. India, over 20 years, and by the way, both of them started from the same spot, these charts. India per capita, how much each Indian gets on health, grew over time because the economy was growing. Okay. And it grew from about $7 to, I think, about 21. I can't say, about $21 per capita. But the red line stayed flat. So, health got more money because the economy grew. China, starting almost at the same place, the economy grew, but the amount of priority for health increased. And as you can see, and at the end of the day, you had the per capita health in China growing to almost $300. So the nuance in this, yes, our economy could grow over the next few years. It is growing, and that's what the fundamentals are saying. But if we then do not further prioritize, like the Chinese, we'll get something, but we could even get more. That's my first message to you, sir. Now, going to run through a couple of things. My second message is, sir, Nigeria has been 2 years of amazing reforms, I must say. Look, round of applause for Nigeria. Let's. And that's the Nigerian president signing what's called the tax reform bill. Estimates have put the tax reform bill to take tax to GDP from about 8% and to modestly to about 12%. Huge. That's it. It was signed 2 weeks ago. But please, recall what I said. Difference between India and China. When the economy grows, as it will grow, we'll get more. Well, you can do better than that. So first opportunity, but second point for you to note, Honorable Minister. I even argue that there's even additional headroom. If we look at excise taxes from tobacco, alcohol, sugar-sweetened beverages, if I look at Nigeria and several other African countries, huge headroom to increase taxes there, which can, yes, further grow the economy, but I am arguing that, in fact, they can also be earmarked into the sector. There's been a lot of pushback, as you can expect, from industry in terms of getting the opportunities here. But it presents additional opportunities for the sector to leverage. My second set of arguments, Honorable Minister, I listened very carefully to your speech. You mentioned something called the social contract. Guess what? Nigeria has been one place where it's doing the right things. We just need to double down on it. So I bring forward a proposal which is now going to be very important for African countries. You call it social contract, I call it the compact. The compact most times doesn't even have the force of law behind it. But it says, you know what? As a people, as a nation, members of the Federal Executive Council, this should stop. This health outcome should stop. What are the things? Let's sign something to take forward. Nigeria has progressed on this compact. It signed a National Health Act. There are two key things in the National Health Act. Two. It provided some financing from the federal government. It also defined a package of services called the Basic Minimum Package of Health Services. And I'll come shortly to why that's useful. You were at this meeting, sir, because you were commissioner in Ogun State at the time. This was the Presidential Summit on Universal Health Coverage, about the first time I met you. So, you probably had to dig out this particular image. We signed something close to a compact at the time, but the National Health Act was not ready. But it laid the foundation for what was to come. So, under this your administration, the president, 12th of December, UHC Day 2023, called all state governors and all partners, and they signed the compact. It might now be important to begin to unpack what that compact truly means. Because the opportunity provided by this changing financial landscape means we need to be very specific. First thing that you want to look at in that compact is what we call the benefit package. Nigeria has already defined its benefit package in the National Health Act to say this is the basic minimum package of health services. So within that compact to say, look, I will deliver this package which costs 10,000 naira to 10 million Nigerians. You don't have to say things you can't do. Because, sir, those are the kind of things ministers of health want to hear. The second thing you want to do in that package, look, Nigeria, and this applies to several other countries as well, we have a social registry that has defined in some granular detail the level of poverty amongst the population. You don't have to cover 100% if you don't have the money. Okay, I will cover the first 3 deciles. I will cover the first 4 deciles because that's what my physical space can accommodate at this time. And I translate that into the compact. So it's not like health is asking for billions and trillions. I'm asking to deliver a package for X number of people based on data that doesn't necessarily belong to health. The next suggestion I have, several African countries, National Hospital Insurance Fund, Kenya, NHIA, Ghana, several African countries, set up national health insurance scheme, Nigeria, NHIA. There's a problem. Guess what? When you fund Ministry of Health and fund hospitals, you're also purchasing services. When you set up insurance entities, you are purchasing services. It only gives you the flexibility to buy from both public and private. What we're seeing across African countries is that we have set up these insurance entities, which is a step towards strategic purchasing, but then we're doing the mixture of the two. We're doing the traditional supply-side financing through the ministries of health. And then because we have set up the health insurance entity, we're putting a bit of that money through the insurance entity. You got to pick. Countries that have followed the traditional supply-side model, a lot of them have achieved UHC. But if you've taken a decision that you want to go the insurance route, then do it. Of course, Ministry of Health people will push back. They will fight you. That's okay. But you need to complete your strategic purchasing reforms. I think there's Mom Connect in the room. People have already, I think Alex talked about digital in health, artificial intelligence. Where's Mom Connect in South Africa? You know, those are the kind of things we need to go to scale. Njide already spoke about PPP models. If you don't leverage private sector partnerships, then it's no work done. And perhaps, if you know you want to leverage the private sector, then maybe that insurance pathway is your own preferred model. Because that insurance model is then what gives you the opportunity to be able to contract with both sectors. Also, there are a few things we're not good at doing. Implementing large-scale initiatives. Someone was telling me about HPV vaccine testing and all that. I give an example of the government of Peru. Contracted Roche. Millions at scale. That's the kind of large-scale contracting you want to do if you want to achieve universal health coverage, but also because we want to capitalize and leverage on the reduced fiscal capability. Amit, you spoke about digital transactions. The numbers in Nigeria are mind-boggling. But you can only leverage this enabler when you have put in place that public financing, those number of beneficiaries, your purchasing entity. That's when technology becomes useful. Ladies and gentlemen, I think at this point, just to close to say that to whom much is given, much is expected. Minister Salako, Minister Pate, I think you've been very fortunate ministers. The president gives you literally anything you ask for. And I like this strategy, and that's why I'm putting it up, so that other countries can learn. Because in the health sector, we don't go back to give account of what we have been given. So this state of health reports that Nigeria has introduced, very useful, more so useful now. Accountability, going back. And by the way, for those who do not know, of course you know our president. But the man standing next to the president is the Minister of Finance. The Because then he's able to say, okay, these people that I'm giving money to, I know what they're using it for. He probably won't open that book, but at least he knows that they've given him a report card. Nigeria is a federation. The only way, maybe not the only way, but one of the ways, sir, that you can actualize that contract, our governors are very powerful, is if we introduce a competition and hold people account for what we're giving them through naming and shaming. Like it was done earlier this year, where some states were awarded some incentives for actually delivering on certain arrangements in the contract. Okay, you have delivered so health outcomes. We're honoring you for that. There are 10 governors here. Only one governor is the winner. But I can assure you that Governor Sowolu, Governor Abdulrazak, Governor Dauda of Zamfara, they were like, okay, what's my state doing? This might look like small things, but these are the kind of things that needs to happen at national level, CDC. These are the kind of things that needs to happen at the AU level if we're going to make a difference. I'll just close by letting everyone know that I have colleagues who are here. They're looking for transactions, Zainab, so that you don't let her go back to Washington with the money she's brought. Shish and Sylvan. So for people who actually are hoping to make some investments on the continent in this sector. So the World Bank is not here to make diagnoses and make propositions, but actually to make a real change. And Minister, will be seeing you later today. Thank you very much.
Wow. You can't argue with any point that Olumide made. Thank you, Olumide, for such a convincing address. Now, ladies and gentlemen, let's talk about harnessing health data and evidence to attract and optimize health investment in Africa. We're talking about financing for health. So I'd like to call on stage Isiwa Oyaniga. She's the, please come on stage. She's a manager English-speaking West Africa at IQVIA. Welcome her with a clap.
Good morning, the Honorable Minister of State for Health, distinguished guests. I'd like to acknowledge the presence of all the dignitaries here, and I adopt the existing protocol established by the previous speakers. Thank you very much, Dr. Olumide, for nicely setting the scene on the healthcare financing background. Could I please have the slides up? Fantastic. So today we'll be briefly speaking about innovative healthcare financing as an avenue to pull in this domestic finance resource gap that we see. But first of all, let's remind ourselves about innovative health domestic financing. Going back. Fantastic. So what we see in Africa is traditionally we have three main sources of healthcare funding. You know, we have donor funding, we have the public funding, and then we have a private funding, which largely comprises of out-of-pocket expenditure and private health insurance. Now, different countries use different mixes of these three sources. For example, you will see that Ghana and Kenya predominantly have maybe about 50%, roughly 50% of government funding, whereas the likes of Uganda and Malawi are more donor reliance on their funding. And then you have Nigeria, Cameroon, which is largely private, out-of-pocket expenditure. So how do we now leverage this? Or what do we need to do to move forward for this? Because this is certainly a gap. or perhaps innovative financing is the solution. And it really isn't anything complex. It's not something so grand. It's really just using alternative methods to supplement this domestic resources for health. Now, what we've seen around the world largely is that there are three main archetypes of innovative healthcare financing. We have the government funding schemes. So I think previous speakers may have alluded to this: sin taxes, micro levies, taxes. We have the multi-sectorial financing, where we look at social or impact development bonds. We have PPPs, that's been spoken about multiple times. And then we can do fundraising from the community. Now, these schemes are actually already being deployed in Africa. We are no stranger to this. We already see the sugar tax in Nigeria, the tobacco taxes, alcohol taxes, AIDS levy in Zimbabwe. And these are already being used to mobilize healthcare insurance, in some instances, to fund NCDs, treatments, and the likes. But what is actually limiting all of this? Why haven't these alternative schemes scaled up in different markets? What can we learn or take away from these different markets? Now, we've looked at all the different success factors. We've done some extensive research, which have been published as well, to see what actually makes these succeed, what enables the initiation of these innovative financing mechanisms, and even the scale-up beyond what is currently in play. And we see across board there are largely three critical success factors: the partnerships and implementation capabilities, coming together, being able to have that close handshake and then implement these financing schemes. The political will, and of course that goes in hand with the enabling environment. And then transparency and accountability. In Africa, data is really the common denominator for all these critical success factors that will allow us to scale up innovative healthcare financing. For example, for the political will, for partnerships and implementation capabilities, if there's better data, we'll be able to understand what the organizations want to do, what is the disease burden, what are the infrastructure gaps, and organizations can plan for impactful collaborations for innovative healthcare financing. If there's better data to demonstrate the return on investment or the cost of really not doing anything or taking any action, then perhaps government will be more encouraged to participate in these innovative financing schemes and create an enabling environment. If there's better data available for us to perform these impact evaluations on the innovative healthcare financing schemes that have occurred, then the stakeholders who have partaken in this are confident and more aware on the resources, how the resources are being used, and what the outcomes are of these innovative financing schemes. So data really is the common thread across the board. Now, I'll pause here for a minute. There's a lot of information on this slide. But essentially, if we walk back from the impact, which is the critical success factors, political will, the enabling environment, transparency and accountability, we can see that the starting points are the data sources, and we have many of these. And all these data sources give us different attributes or different pieces of information that allow us to do all sorts of analysis. So for example, if we want to understand the return of investment to drive that will be beneficial, in driving the political will, we may want to look at the disease burden, the cost per benefit, and all of that. But all that information will ultimately come from disease registries or claims data or EMRs. Now, these data sources are actually available here in Africa. But the challenge is the quality of these data sources is largely limited. For example, if we look at disease registries, Information there is perhaps not updated regularly. The information there is not properly linked. Claims data, the information on the claims data is not sufficient. It doesn't have good coverage or capture of the entire picture at hand. The LMIS data, for example, only captures or predominantly captures information on programs, disease programs, so you don't have that full visibility of the entire supply chain. So in many markets where these data sources are available and robust, they have been able to do all sorts of evaluations to assess the impact and even accelerate and drive this innovative healthcare financing at a fraction of the time and the cost that we would do these evaluations here in Nigeria, because you're able to leverage a lot of machine learning and artificial intelligence, all because those data sources are available and robust. So the first step for us really here is to have the right data sources from the onset. We need to focus on ensuring that the data we have in our different spheres of influence, we're ensuring that this data is accurately captured, adequately kept, and properly stored. And working towards this will enable us drive towards having impactful initiatives and drive the scale up, the initiation and scale up of these innovative financing mechanisms. So I charge you all to go ahead, wherever you are, support the development of these data sources, the disease registries, the LMIS systems. Ensure that the information is properly captured and readily available, because at the end of the day, we're looking for that impact to drive these innovative financing mechanisms. Thank you very much.
Thank you, Isiwa. Very eloquently put. As our financing panel gets ready, gets their microphones affixed, Dr. Ola Brown, please come to the media team for miking. I would like us to hear a word from one of our partners. Thank you, Roche, for everything you do to avail medicines and diagnostics in Africa. Please come on stage. Community Director, ECH Alliance, the Global Health Connector, Mr. Andy Bleeden, welcome on stage for a panel discussion. The Head of Policy, Population Health and Health System Strengthening at Roche Pharma Africa, Dr. Paul Chilwesa, please welcome on stage. Dr. Ola Brown, I don't know if you've made it back to the room. You can come on stage. She's coming in a minute. And the moderator of this panel will be the Global Sector Lead for Health Services and Emerging Markets at IFC, Sylvan Chikengezo. Welcome.
Thank you. Thank you. You can go ahead and take a seat, sir. Great seeing you, Paul. You can go ahead and take a seat, sir.
Dr. Ola Brown, please welcome on stage. Give her a hand, the founder of Health Cup Africa.
Thank you. Fantastic. Please go ahead and take your seats. Well, a very good morning to you, everyone. Of course, we are grateful to have the minister here. You have to leave. Thank you, sir, for... No, fantastic. We'll go ahead in the meanwhile. So thank you for coming through today, and we're really quite honored to sort of come through as a follow-up to the conversations that happened, of course, starting with the great minister, who I think really laid a good base for the conversation that we are about to get into today. And of course, grateful to my colleague Olamide and our colleague from IQVIA, who at least set a good stage on the stacking realities that we, of course, face in Africa, right? 24% of the disease burden globally sits here in Africa, whilst only about, less than 4% or 3% of the GDP in health financing in most of the African countries is where we see. But if you look at other countries globally, say, for instance, countries such as Poland or in Europe, they're looking at anything as high as 6 or 7% in regards to health funding from a GDP perspective. So I think the gap in the reality is really stacking. But I believe that the opportunity in Africa is also huge, right? I believe that in Africa over the last couple of years, we have seen Africa being home now to over 600 healthcare startups, particularly in the tech space, which actually alludes to the great opportunity. And I'm hoping today we can use this opportunity, with my panelists with me here up, to just give us a sense on a few practical solutions on how we can close the needle, particularly from a health financing perspective. So probably I'll give them an opportunity to quickly introduce themselves and give us a high-level snippet on how each of their organizations or in the spheres that they operate in, how they are making really that dent from a healthcare financing perspective. Paul, do you want to kick us off?
There we go. Thank you, Sylvian, and thanks for the invitation. This is, I think, a great opportunity to share.
Can't?
Is my mic on? No. Can I just use the other mic?
Can we borrow this?
Do you want to use
this
one?
I think I'll make use of the right mic. I think thank you a lot again to the AHB for the invitation and the IFC for hosting this panel session. So my name is Paul Chilwesa. By background, I'm a clinical oncologist trained on the continent in South Africa, specialized in breast cancer. I've been with Roche for 4 years where I had policy, basically how do we change the life science ecosystem using data and evidence. Population health, I think you saw the video. How do we contribute to outcomes that are so dismal in Africa? And health system strengthening and shaping, which basically looking at how do we invest collaboratively towards improving those outcomes and changing the life science ecosystem in Africa. Thank you.
Thanks, Paul. Andy?
So, can you hear me with this?
Yep.
Lovely. I'll give you that one. I just thought it was a hairband. But my name's Andy Bleeden. I work for the Global Health Connector, ECH Alliance. Our role here, thanks to our partnership with AHB, is to ensure that the messages we're getting from Africa are made louder across the globe. So we use a network of global health ecosystems. We're about to launch one this week in Nigeria, our first in Nigeria. But our convening ability ensures that the voice of Africa is loud, not only in Africa, but across the US, Europe, Asia, and beyond. Because we see opportunity here. And I recognize having to come after a fantastic presentation around from the World Bank, the opportunities that are there that need grasping. So we're happy to help with that as the Global Health Connector.
Thank you. Thank you.
My name is Dr. Ola Brown, and I run a venture capital firm. The best way to explain what a venture capital firm does is it's like a bank, but instead of providing big companies with debt, we provide small startup companies with equity and help them grow into big companies. And we specialize in health. We're one of the only venture firms in the world, in Africa, that specialize in the early stage financing of healthcare innovation. And that means that we occupy a particularly unique area of the ecosystem where we specialize in assisting health tech founders to go from startup to scale. And we focus on 4 major markets where we deploy capital: Nigeria, Kenya, Egypt, and South Africa. So far, we've invested in over 16 companies who have created over 1,000 jobs, serving 2 million patients in 10 countries across Africa. So it's great to be here and speak to the level of impact that the innovation ecosystem is having in Africa and beyond.
Thank you. Thank you so much. So, Dr. Ola, I'm going to start with you just very quickly. Over 16 health startups that you've invested in, 100 million deployed in different ways, over 2 million patients that are touched. Is that on an annual basis? I'm just curious, right? Because we do have a lot of health tech and entrepreneurs in the audience today. Some of them, look, have got projects that are either in the grassroots, looking to scale up, and you have had an opportunity, right, to invest in projects that have scaled up, that have invested, and that have had an impact in the ecosystem. So, from your perspective, what are some of the key tools that you have used really to galvanize and bring more capital, particularly into Africa, seeing some of the health gaps that we particularly see that the public sector brings on board?
So really, you're asking how I raised my funds. So I think that healthcare is always a more complex sell than agriculture or fintech. And I think it's about really having an expert team that specializes in these areas and can show investors in the fund a pathway to returns. Venture capital is not a game of grant giving, it's not a game of philanthropy, it's a game of rapid scale. So I think number one, I'm a physician by background, so I'm a medical doctor, emergency medicine. My master's is in finance, my PhD is also in finance. So understanding both healthcare as a clinician, as an academic, as well as financing kind of helps attract investors. And my team as well have a mix of those skills. So we're really, really good at helping healthcare companies. I'm also a former founder. So I founded one of the largest emergency services companies in West Africa. And I think that founding a company as a medical doctor, I had a very unique experience, again, from most people that start businesses, because I had to learn. I spent 6 years learning what I thought qualified me to start a business, and then realized that there's a whole other language of business. And most of our founders are like me. They're doctors, they're pharmacists, they're lab scientists, they're PhDs in neuroscience. And our firm is able to equip them with all the other stuff that they need, business development, accounting, HR, marketing, that helps them achieve that scale.
Thank you. It's quite interesting, and I'll stay with you just for a minute, that you mentioned that it's not about grants and everything, but to what extent do you go beyond financing? You know, one of the things that we do at the IFC is, some might know us as a financing house, but we are literally beyond the financing house, right? There's a lot of technical assistance that we bring on board, particularly in health especially, that deals with issues on quality, issues on ethics, and the like. I'll be just curious to understand, to say, when you are also, funding and putting some of these innovative products, what are some of the things that you practically put on the table that go beyond funding?
That's such an interesting question, and it speaks to the heart of what we do. And I think the difference between public markets and private markets. So almost 80% of all companies earning over $100 million a year in the world are in the private markets. But the investment community seems very, very focused on the public markets. Now, public market investors don't really add so much value to the companies. You invest in Zenith Bank, And you expect Zenith Bank to give you results at the end of the day, but it's not like you're speaking to the CFO or the marketing team every day of Zenith. You have the stock and you expect your dividend at the end of the year. Private markets are quite different. In venture capital and private equity, the expectation is that we're offering more than money from day one. So we help our founders in 4 main areas. We help them in business development and marketing. Every sort of small, early stage business probably does marketing worse than you would expect a large company to do because they don't have the big budgets that large companies have. So we assist them with business development and marketing, which is essential for scale. We assist them with strategy. We assist them with HR, recruiting, and we assist them to fundraise further on for further rounds, so either from private equity companies, from strategic partners, or from investors that invest at later stages.
Great, and great to see that you go beyond that. Into the audience, please feel free to get your questions ready, because just after this round of questions, we're going to be coming to you to get more engagement and get your questions on. Andy, I'll look to you for a minute. You know, at ES Alliance, one of the things that you excel in, I believe, is connecting stakeholders, right? It would be useful for you to elaborate in more detail how you specifically facilitate the connection, particularly for global and regional, you know, investors. I think we tend to see a huge gap in that space. And are there any specific platforms or initiatives that you have found to be more effective, particularly in that matchmaking process?
Okay, I'll give you 2 examples. So I'm going to do national and then global, if I may. So an example here, this week in Nigeria, we're going to be launching a national ecosystem targeting cancer alongside the Nigerian Cancer Society. And we use that as a convening ability to bring all the stakeholders of health together, be it healthcare providers, patient organizations, researchers, industry, financiers, because that convening ability means that we can then use that tool to match need and solution, whether it's on the topic this week, such as cancer, or in Bangladesh, where we launched just recently, on the topic around women's health. So using that same ability to break down silos in healthcare allows investors to take part because we act as a neutral, honest broker. It allows patients to get a voice first. And it also means that we can actually get stuff done, because by actually bringing those players together, giving them the ability to be able to look for areas where they can match need and solution, it leads to action. Because we have this mantra about doing stuff as opposed to talking about doing stuff. And you saw some messages earlier on about that. Secondly, on a global scale, what we've done is use our ability to bring convergence. So we're looking to bring together not just health players, not just science, but also economic players and finance. Why? Because without those, this is empty words. Because that's where, as you saw with the previous speaker from the World Bank, having a Ministry of Finance involved is crucial for accountability and also to ensure outcomes. Having the economic development people involved are also crucial, because if you can imagine like a country where I'm from, in England, one of our largest spends is on healthcare. Great levels of spending, pretty poor outcomes. And I'm embarrassed to say that. We waste money in healthcare. However, by bringing the economic development people in, they understand the value to the country of that spend. So that idea of bringing convergence outside of healthcare to bring finance, economy, health, and science is crucial on a global way to get investors to pay attention and also see the value of getting involved.
Fantastic. And in some of the practical solutions, especially from a funding perspective, right, we tend to see that most organizations will target the large, institutions or scalable platforms. But I believe that innovation is really in the grassroots. Mm-hmm. And from your perspective, what have you seen to be that thing that will help catalyze funding, particularly for those projects that typically will be in the grassroots? And that's where the innovation really comes from, right? And it would be great to get any practical examples that you have seen on your end.
So one of the ideas with our ecosystems model is, as well as hearing from the needs, so you'd hear, for instance, on cancer, what's the need from patients, healthcare professionals, researchers, what data do we need, what do policymakers need to understand in terms of trends? That's one side. On the other side, we look at what does good look like in Nigeria? What's good practice, best practice north and south in Nigeria, across the country, but also outside of Nigeria. And then lastly, and this is the crucial bit, get a pitch competition going, because that ensures local solutions are given airtime, they're exposed to finances, they're exposed to those people they want to sell to. Because you've already got on stage the patient organizations, the hospitals, the buyers. So using that pitch program works. And we've seen that in countries all over the globe. And there's nothing scarier than sitting, as you'll see later this week, sitting on a panel with a big man like me with a stopwatch saying, you've got 1 minute, one slide, get on with it and sell. It really helps get people's message across about what solutions work.
Thank you so much. Paul, I'm going to look to you now. I think as Roche, I know you are very active right across Africa from an R&D perspective. And we believe that R&D partnerships are, of course, critical to innovation, particularly in most of the countries that we operate in. I'd be quite curious to get a sense from you how you as Roche are using your global scale, your experience, particularly in R&D and in innovation, particularly in areas of diagnostics, treatment, and vaccines, to particularly help galvanize health financing within African context.
Is this working better now?
Yeah.
Thank you. I think one of the first of all, I wanted to start from saying among the biotech companies existing in Africa, I think Roche has one advantage that we've got diagnostics and pharmaceutical under one umbrella. The third pillar is we also have a lot of data science with us. So we sort of contribute from pharmaceutical, which is sort of your last mile treatment, and you've got diagnosis, which is sort of upstream work, and you've got data end to end. I think one of the approach that we've taken as a company in Africa is look at health as an ecosystem, a life science ecosystem. And I think I'll break it down into 4 pillars in where we are actively involved. First of all is, how do we understand our healthcare? Do we actually understand our African healthcare and our challenges? We've seen a lot of data and publications that have shown some genetic diversity in Africa. And from that end, which is early research and development, we have invested in a project called Africa Genomic Project with on-the-ground local partnerships. I think one of them that was announced this year is called Yemachi, a startup biotech in Ghana, to understand, do we actually understand the genetic data on how it contributes to disease? That's really critical, so that when we look at healthcare as an investment, we are putting the right money in the right areas, which will give us the right outcome. And we also partner with local universities. In the same Africa Genomic Project, we've partnered with Wits University in South Africa, so that we are more aligned with the local healthcare systems and not translating of our data from the Western countries. I think the second pillar, which we talk about in R&D, but a bit more loosely, is sort of your late-stage R&D. So I've talked about the early stage and the late-stage R&D, which is a critical issue. I think I saw the colleague from CDC and the WHO. We've heard of antimicrobial resistance as one of the biggest challenges we are facing in Africa. And if there's something that would take away the health as an investment into cost, tremendously, is exactly that. As Roche, we have a product which is in the late phase, and Africa has been prioritized. 3 countries have been prioritized to have this research done on the continent with local partners. The third element, I know we talk about R&D and we talk about manufacturing, but actual investments on the ground in the diagnostic infrastructure. So we have 3 countries that have actually, Egypt, Morocco, and South Africa, with a big investment in diagnostics. If you look at the genomic-wide sequencing, 70% of those are actually produced in Cape Town in South Africa. The last piece, which I think is critical, and I think the minister alluded to that, we are seeing a lot of brain drain in the critical skills. And I think Roche, especially if you look at Nigeria itself, if you look at Cote d'Ivoire, there are a lot of systems that are helping build these skills capabilities to ensure that we are treating within our continent, and we are also transferring skills within the ecosystem. So I think it's to understand that diagnostics, pharmaceutical, and data, if we understand this end to end, we will be able to contribute data into the life sciences in Africa.
Interesting. And unfortunately, the minister has left. But one last question, and I'll probably be looking to the audience. So maybe if we've got a mic, let's probably have a mic roaming in the audience, and we'll probably take a few questions from the audience in a minute. But very quickly, Paul, one of the things is the funding gap is huge, and the public sector can't do that alone, right?
Absolutely.
So from your perspective as Roche, what would be the 2-3 things that probably come to mind that we probably need to do better, or that you have probably seen in other regions that are done better to help galvanize and grow that space for private sector to do more within the health space?
Thank you, Sylvia. And I think I want to go to the slide Dr. Olomide showed in China comparing to India. And it's one of the big pillars in Roche in data and evidence. When we are talking about healthcare as an investment, they need to be a measurable outcome. Yeah. I think that's how investments work. And one of the outcomes is this progressive improvement in the people we are treating. We see a disjointedness between can we prevent and screen disease investments, and the ones that are found with disease, can we treat them comprehensively end to end? What happens in the system, I think we've seen this across different markets, is we get diagnosis, we get screening done, but patients wait more than 60 days according to the WHO guidelines. So we've put so much money in the screening, but those outcomes are not secured. So patients end up showing up quite late. So I think we need more investments in the healthcare for sure, but we need also have efficiencies in our integration. Can we be more efficient in how we ensure that these systems are connected? When you talk to a screening system in Africa or an NGO supporting screening, you ask them where patients will get treated. A lot of times they have no clue. Or it becomes a responsibility of the family or the government to do that. But I think we need to have these conversations in the way we integrate healthcare. Can we ensure that our investments in the upstream are producing results in the downstream as well?
Outcomes. Well, that's quite interesting. Now I'm looking to the audience to see if anyone has got a quick question or two, probably to pass on to the panelists here. So I'll probably going once. Okay, we have a question right at the back of the room, and as we get ready for that question to come through, anyone else? Right here, we have another question right here in front. Probably if we can have another mic. Please, why don't you go ahead, another one here. So we'll probably take those 3 questions for now and to see how we go from here. Sir, please go ahead.
Thank you very much. Quite a privilege to be here. Something Dr. Ramit Thakkar said stayed with me, healthcare in their pockets. And my question has to do with this. To the panelists and anyone here present, what opportunities are available for startups who have already, like we do, or are developing mobile apps for quick enrollment to the Nigerian health insurance system currently? Startups that have innovative solutions such as opening back ends for HMOs to access, back ends for service providers to access. As far as I know, and if anyone from NHIA is here, please correct me, there are no current operational guidelines for third-party administrators. It was almost ready, but while the government has been working on SWAP, we haven't had any news on that. So I'm quite interested with what Ola Brown said and what the discussion of health as an investment. Thank you.
Thank you. Thank you very much. Dr. Ola Brown, you want to take that briefly? And yeah, you can give a few remarks on it. Probably just wait for one more question, then we can go ahead, sir.
Thank you. Thank you. I'm Dr. Benson Ayodele Cole, Vice President, One Healthcare Federation of Nigeria. Now, I'm just curious to know how we can have a better systemic approach to improving the ills of healthcare in Africa, not just Nigeria? Can we have a systemic approach that says from bottom up, strengthening primary care? When we've achieved our aim there, we advance to secondary care, strengthening that segment, and then to the tertiary institutions. Or we devise another scheme that could be top-bottom approach, start from strengthening our tertiary institution, public and private, cascade down to the secondary care levels, and then to ensure that primary health care is taken care of. Why are our leaders dying overseas? Is it primary care they go there for, or tertiary care? What do we need to do in the immediate, systemically, with clear-cut expected outcomes? So whether we're starting top-bottom or bottom-up. Because what I see us doing is like fighting multiple fires in different places. And I don't think that will help us a lot. Thank you.
Thank you very much, sir. Andy, can I throw that to you, probably? You can just give it, that to you, probably just give a sense on, how you see it in the ecosystem, probably. But we'll come to it in a minute. We'll take one more last question, then Andy, you can respond to that.
Thank you. Hello, my name is Jackie Karachi, and I've been in the healthcare space in Africa for about 20 years. My question is for you, Dr. Brown. I'm very happy that you're putting your action where your money is in healthcare startups in Africa. I wanted to ask, you mentioned about over 600 startups in healthcare on the continent, but are you focused on a specific group of healthcare startups, so more focused on AI, more focused on local manufacturing, for example, or more focused on the service delivery end of the healthcare space? The reason I ask that is that I feel that there are specific groups of startups that have, dominated, quote unquote, over the last, let's say, 10 years in healthcare. But where we are seeing interest, for example, for local manufacturing, it's still quite weak. And I think there are many players in this room that can speak to a few other verticals that can be linked to particularly local manufacturing in Africa. So if you can speak to financing in that space, I would appreciate it. Thank you.
Thank you. So we'll come back for another round of questions. So Dr. Ola Blount, probably two questions for you. Health tech companies that are looking to integrate particularly into the public sector system, probably I can broaden it, just not to say beyond what they're doing in their own cohort, but what can they do to integrate particularly with the public sector would be great. Then, of course, this question that just came through as well from your perspective.
For startups looking to integrate and building for the public sector, in our experience, we find that's just a quick way to go bankrupt. We find that you've got to build and have a few clients that are in the private sector first. Even the Bureau of Public Procurement, for instance, they require you to have audited accounts, tax, all kinds of documents that you need to have a track record before you can do these big government contracts. And the level of documentation you need to even put in a bid for some of these government contracts and get through the Bureau of Public Procurement protocols means that you need to have FIRS tax clearance of 3 years, you need to have audited accounts for 3 years, you need to have a standard sort of board of directors, and you need to have cash to lobby and be flying to Abuja at least every week from Lagos to be able to get these contracts. And you need to be able to appeal to different sorts of stakeholders. And then you need to have the cash from the private sector to even hold on for the 120 days to when government will even pay you. So I think it's very, very, very difficult for new startups to build for the public sector, unless you are very well connected. In general, we find that the ways that startups have been able to eventually work for the public sector is by first getting a track record with the private sector and then using the cash flow and the resources and obviously all the documentation that you need to bid to be able to then approach the public sector in a much more robust way. That's our experience. Other experiences in the room might differ from that, but I would say, get your first few private sector clients first, unless you have more connections than me.
Yeah, Andy, do you want to elaborate on that point?
No, because it's correct. Because go local or go private first.
Yeah.
Because there's no way, if you want to enter, for instance, into the NHS, all you see is billions of dollars and pounds available. There's no chance of getting a contract in that bloated, overweight, overfed system that's overregulated. Not a chance. So I completely agree.
That's interesting. So, Dr. Ola, before you go on to that next one, probably I'll flip it. I want Paul just to make a quick comment and remark from the question that came here, right?
Yeah.
And Andy, you probably come into this. So, better systemic approach, is it bottom-up or is it top-down? Is it primary care first or is it tertiary first? How, probably as Roche, how do you see it and how do you approach it?
I think let me speak away from Roche on this one, if I may.
Sure, please.
I think we need to redefine health and healthcare in Africa. And I'll using examples. If you are in Europe and you've got a health idea or a health investment, it does not go to the Ministry of Health. It goes in Ministry of Health, Economy and Development. Those discussions happen differently. In Africa, as we sit here, the common person here is from health. But the rest of the world, healthcare is not only for the Ministry of Health. Healthcare is part of the economy. I think that's the starting point. The second piece, which I think is a bit more political, and CDC Africa and AU, 1963, the AU was created. By 2063, we want to see every African country achieve middle income status. What we have not defined in there is how healthcare will contribute to that. We haven't. I haven't seen it. I've tried to read that document. We haven't. If you look at China and if you look at other developing countries, they have a very clear definition of how healthcare will contribute to that. So I don't think it's a bottom-up, top-down. I don't think so. The second piece, and I'll end with that, 2018, we had a standard declaration. Very clear, very precise. Primary healthcare is the backbone. If we achieve primary healthcare, 80% of our healthcare problems go away. 80%. We then underwhelm the tertiary care. Right now, it's the reverse. 80% of problems are ending up in tertiary care. Doesn't matter how many people we throw in those hospitals, we will not achieve it. So we need to ensure that we achieve what we sign up to. Every African country is a signatory to the standard declaration. I have seen this. 2018, we are now 2025. How many are achieving these primary healthcare investments so that 80% of the diseases are not ending up in hospital?
Yeah.
So I think we need to first of all redefine, achieve what we've signed up to, and at the continental level as AU, we need to hold true to what we want to achieve.
Yeah, okay, so there's no one standard, right? I think it's mostly fit for purpose, depending at the level of evolution where the country is. But of course, developing primary care, I think, is always going to be very critical, right? And I think we as IFC, it's definitely a big area of great focus for us. We intend over the next couple of years to continue deploying more capital, particularly in development of primary health care. But the idea is finding the right scalable and economically sustainable models that we can work alongside with, of course, with all our technical assistance that we provide alongside with it. So we'll be happy to have conversations with any entrepreneurs who have got ideas that they are working on, particularly to develop that space within primary care. But of course, it's not only that, but right across the whole health ecosystem. Dr. Ola, there's one more question that, of course, came for you, right? I'll be happy for you to probably attend to that and be happy to take 2 more questions as we probably come to a round.
So there's a lot of opportunities to connect with investors in healthcare. There's venture capital investors, there's people that invest in private equity, there's angel investors, and obviously there's bank debt like development banks like BOI, there's development banks like IFC, and they all offer different forms of funding. Private equity, ideally, you'd be doing over $10 million a year in revenue. Early stage VC funding, you have to have some sort of technology element to your business. and that's a segment that venture capital deals with. Banks, anything with cash flow, they'll fund as long as you have collateral, and if you can't pay back, they'll take your father's house. The development banks are a bit more laid back, and you can restructure that kind of debt. But there's a whole universe of funders and funding, depending on the kind of business that you're building. But I think in all of this universe, there's one thing that's pretty common, that they want businesses that are profitable or approaching profit, relatively fast growing, and have good cash flows. And that's something that, you know, the private sector is very different from grant funding in that, like, there's a level of monitoring that you wouldn't get from a grant. So for us, we are in the technology space. We invest in the earlier stages. Usually our companies are very, very early on, and they have some sort of technology element, and we primarily focus on Nigeria, Kenya, Egypt, and South Africa.
Fantastic. Look, I would love to take a few more questions, but look, the panelists are here, and they'll be happy to probably, you know, answer some of your questions. So I want to round up now before Daniela pulls the chair off here. Just to quickly, Paul, do you want to make a few just closing remarks, and I'll go with Andy, then end with Dr. Brown, and we take it up from there. Paul?
Sure. So I think I will just reference two events that I've actually been incredibly proud of to have either participated or watched. I think one of them was Bill Gates being here, and I'll paraphrase what he said. He says human capital investment is in health and education, which forms the backbone of sustainable economic growth. In the long run, your human capital is your main base of competition. Until we realize that a healthcare investment is part of a competitive edge as Africa, I think these conversations continue. And the second one, I think, Sylvan, we met in Washington at the spring meeting. I think there was a slide that I took away at this year's spring meeting of the World Bank and IMF, where they said there are large-scale spatial gaps in delivery of education and human services, health services. What is missing is the quality is a major concern. And quality is just not saying we give treatment. Quality is we invested in screening.
Yeah.
This patient was referred into the treatment center, and they got a comprehensive package, and they didn't pay out of pocket. Thank you.
That's a very good point, Paul, and I really like that. It's really the quality, right? And I think access and quality should really be at the core of what healthcare funding is about, and that's what we look at. Now, of course, we want it to be economically sustainable so that at least it can go into posterity. But quality and access, I think, very critical points. No, thanks for that, Paul. Andy, any closing remarks from your end?
3 points. First point, break down silos in healthcare. We have a lovely habit of working in our own little spaces and forgetting to tell everybody what we're doing. And a lot of time, that's a lot of wasted effort. I'll give you an example. We work with a country that will remain anonymous, Northern Ireland. What happened there, I'll link that out, but we work with a company that we work with the Ministry of Economy to say, look, our largest spender in this country, the largest employer, the largest procurer of funds, the largest procurer of equipment, do you have, as the Economic Development Officer, a client manager for them? No. Do you have anybody that meets them? No. And yet, if it was an AI product or a solar panel for the roof, they'd have people lining up, there'd be business breakfasts, etc. We introduced the Ministry of Economy to the Ministry of Health. They'd never met. Never met. 2, don't reinvent the wheel. We've got products on the market that work. They've been involved with pilots that have been tested by people with many more qualifications than I'm even interested in reading about. They work. If it works in one country with somebody with diabetes, it's going to work in your country. It doesn't necessarily have to be tested locally to the same exacting standards yet again. So don't reinvent the wheel. And then lastly, make sure you lead with the need when you're doing work in ecosystems. So you bring the need first. The shiny stuff can wait until afterwards. But if you lead with a need, where there is patient living with, carer of, or healthcare provider, you're not going to go wrong. That's my 3.
I like that. Thank you so much. Definitely you need to live with the need, and we need to create instruments and tools that sort of answer to the needs that, of course, are there, right? Dr. Ola, I'm sure you have the solutions, some of the instruments and tools, but happy to get your final remarks and thoughts on this.
I'm going to do better. 1 point. And my 1 point is that healthcare is expensive. When the governments are paying for healthcare, like in the NHS, they complain. It's taking most of the budget. We can't afford it. There are waiting lists. This is so awful. When people are paying out of pocket, like in Nigeria, they complain. We can't afford it. It's the biggest cause of bankruptcy for families all over the world. It's healthcare costs. When insurance companies are paying, we complain. And if anybody remembers, tragically, a few months ago, actually, the CEO of the largest insurance company in America was killed, point blank on the street. And Americans, if you go to Twitter, which is an insane place, people were actually like calling the guy a hero because he's taking revenge for all of their sorts of refused claims in their minds and the poor experiences that they've had with health insurance. And what nobody is realizing is the underlying thing is expensive. And we've seen that all over the world, when something is expensive, only innovation brings the cost down. But unfortunately, in America and in Europe, what are the major innovations? TikTok, Facebook. We've been curing boredom, but we haven't been curing disease. And I think that African innovators have different sets of problems. Our problem on this continent isn't boredom. And I think that presents a real opportunity for African innovators to solve problems, not just in Africa, but for the world. Thank you.
Thank you so much, Dr. Ola, and thank you so much to our great panelists, and thank you so much to your great audience. Well, thank you so much, and we'll call it quits from here. Thank you, Daniela. Back to you.
Wonderful.
Please remain on stage for a photo. Is Olumide Okunola still in the room? And Isiua? Okay. Isiua, are you here? Okay. So as the panelists take their photo, please give them another hand.
Thank you.
They've given us plenty to think about, that we have to harness the power of data. We have to build sustainable health financing models in Africa. We have to be bold and proactive. We have to capture the power of community ecosystems. We must reduce waste, and we must figure out the formula for making investing in primary healthcare profitable. Now, I'd like to release you for your lunch in Tamarind A and B room. For those of you who've been invited to the abnormal uterine bleeding session, it is in Obesha room. For those of you who are going for the HPV session, your lunch is in Acacia room. And for the rest of us, we'll enjoy our networking lunch at Tamarind A and B rooms. Please be back here at 2:25 for our hard start at 2:30 for the afternoon session. Please scan the code to get a report of some work that we've done on health financing with Roche. If you can put up the slide, it's a good report for your reading. Enjoy your lunch. See you in the afternoon.